Excellent. Okay, well, now we'll get started. So good afternoon, everyone, and thank you for joining us today for our first workshop for this rulemaking. I am Amelia Boyd, and I am the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. Attendees, please remain muted unless you are speaking, and if you have a question, please use the raise your hand function or put your question in the chat. I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. Get this pulled back up here. So, Dr. Chang, would you go ahead and introduce yourself?
Hi, this is Dr. Poshin Chang, a family physician. I'm also one of the Washington Medical Commission commissioner.
Thank you. Dr. Curry?
Hi, Diana Curry. I'm an OBGYN and a commissioner.
And Mr. Farrell?
Hello, everyone. I'm Michael Farrell. I'm the supervising staff attorney for the commission.
Heather Carter?
Good afternoon. I'm Heather Carter, Assistant Attorney General, and I'm the legal advisor for the commission.
Thank you. Mr. Lopez?
Hi there, Lopez. I'm a PA and a commissioner for Washington State, and I'm a hospitalist.
Thank you. Then I don't want to put you on the spot, Marlon, but if you could introduce yourself, that would be lovely.
Yeah, hello everyone. Marlon Basco. I'm a policy analyst with the Department of Health, and I support Amelia with rules work.
Thank you. And then Dr. Domino, if you would go ahead and introduce yourself and then start the script.
Okay, before I introduce myself, my computer says too quiet. Can you hear me?
So that little notice is my computer where I'm at.
Okay, thank you.
So you can ignore that in the corner.
Okay, good. I was on your slide, so I was worried about it. Anyway, I'm Karen Domino. I'm the chair of the Medical Commission. And we'll get started. Today is Wednesday, July 31st, and it is now, according to the computer, 3:34 p.m. This meeting is being held via Teams webinar and in person at the Department of Health in room 166, located on 111 Israel Road, Southeast in Tumwater, Washington. The rule being discussed today is regulating the use of nitrous oxide in office-based surgical settings. Ms. Boyd, please give us a overview of the rules process and the proposed timeline.
Thank you. So since this is our first workshop for this rule, we're going to talk a little bit about the rules process and what is a rule. So a rule or regulation is a written requirement that applies broadly across a group of individuals or entities that enables, guides, or directs them to do something or prohibits them from doing something. Specifically, a rule establishes or subjects individuals or entities to penalties if it is violated, is a qualification or requirement that gives a benefit or privilege, or sets qualifications or standards that an individual or entity must meet to get a license or permit, or sets standards that must be met before a product or material can be sold. So why should we create a rule? Creating a rule for the use of nitrous oxide in office-based settings is essential for several reasons. First, patient safety. Establishing clearer rules ensures that the use of nitrous oxide is safe for patients. Specific conditions and safeguards help prevent complications and ensure that patients receive appropriate care. Consistent standards. A rule provides a standardized approach to the administration of nitrous oxide. This consistency helps ensure that all physicians and facilities adhere to the same high standards of care. Continuing competency. By requiring continuing medical education and certification in advanced resuscitative techniques, the rule ensures that healthcare practitioners remain competent and up to date with the latest practices in nitrous oxide administration and patient resuscitation. And then regulatory clarity. The rule clarifies the regulatory requirements and exemptions for the use of nitrous oxide, reducing confusion and helping healthcare providers understand their responsibilities. Minimizing risks, specific conditions such as the prohibition of combining nitrous oxide with other inhaled anesthetics or sedatives, and ensuring the presence of advanced resuscitative capabilities minimize the risks associated with its use. Then protecting staff, requiring a scavenging system to remove excess nitrous oxide from the procedure room protects healthcare staff from potential exposure, ensuring a safer work environment. Then mandating documentation, mandating comprehensive and accurate medical records promotes accountability and enables better tracking of patient outcomes and any adverse events. And then emergency preparedness, having a documented plan for transferring patients to a hospital in case of complications ensures that patients are prepared or facilities are prepared to handle emergencies effectively. And then finally, security, ensuring that nitrous oxide is stored securely and is accessible only by authorized individuals, helps prevent misuse or unauthorized access, enhancing overall safety. And then the proposed rule development timeline will look something like this. It depends on how many rule workshops we have, whether we can stick to this timeline, but this is, again, is just a proposed timeline.
Thank you very much, Ms. Boyd. Are there any questions regarding the rules process and the proposed timeline? I can't see everyone on my screen, so Ms. Boyd, if you see a hand raised, please call on it, the person.
I do not see any hands raised.
Okay, the next item on the agenda is the presentation of draft language. Ms. Boyd, please present the proposed draft language.
Okay. Get it pulled up. So the first part we will talk about is the existing rule. So this is the existing section regarding office-based surgical settings. And we are proposing one change in this particular section. Let me scroll down to it. Is way down here. So we're proposing adding to the exemption subsection of this section, using nitrous oxide under the requirements in WAC 246-919-603, which is the proposed new section. So we are proposing adding that in there. That way, if they read this section only, they'll be referred to the new section that is all about nitrous oxide. Let me pull up the new section. Screen gymnastics over here. Apologies. So this is our new section, which is in the packet. And so our task here today is just to discuss this proposed language, make any changes. Since this is not an existing rule, we will not be making the changes with tracked changes. So it will be a little less confusing and more clean. So if you want to make any changes to any part of this new section, we can, well, that is what we are supposed to work on today. So I'm not sure if anyone's had a chance to look at this draft language, but you are welcome to change any part of it.
I don't know. I looked at it before, and I think when it went through policy, and I thought the proposed changes were excellent myself, and I don't recommend any other changes.
I like to tend to agree.
Sorry. should I raise my hand or should I speak out?
You can speak
No,
out.
go ahead, Dr. Curry.
Okay.
Just
Okay.
speak up.
This is Diana Curry. I had a couple questions and they might be sort of for you, Karen. Probably having more expertise in this, but couple things. First of a small thing, based on one of the comments, there was a concern about using this under children under 1 by one of the people that wrote in. And I just wasn't sure if we needed to put anything in this to address age groups or if that was a concern. And then my other question had to do with the sort of need for resuscitative equipment and all of that. And I know that a lot of offices don't necessarily have like a crash cart and oxygen and wall section and just all the things that we take for granted in a ambulatory surgery center or a hospital setting. And I'm wondering if we need to, like, if my manager read this and said, oh, we want to use nitrous, what do we need to do to get our office ready? I feel like she would come to me and go, okay, what do we need? Because it's kind of vague, like the resuscitative equipment, but maybe it's meant to be that way. So I just wanted to ask what everyone thought of that.
Well, we did mention you need ACLS provisions,
Right.
certified providers, and part of ACLS does include resuscitation equipment. So I think it was just, I mean, you certainly can add that in that you need the facility,
I
the
know.
equipment.
I
Yeah,
so really like ACLS is a crash cart with all the meds and like
right.
everything. So
Yes,
I
and a
just
defibrillator.
right. So I wasn't sure if we can just assume that people will understand that or if we need to make that more explicit. That's all. That's why I was bringing it up, really.
I have no objections with making it more specific. I see DL, I don't know who that is, but
Hi. So,
Dina?
my name is Dina Levin. I'm a OBGYN in Coopville, Washington at Whidbey Health. I was at Peace Health in Bellingham before that. And we're really interested in starting a nitrous to do like IUD insertions and biopsies, things like that. So our anesthesia providers brought up that we should be having like suction in the office and oxygen, but having a crash cart and having a CLS provider and having a defibrillator doesn't mean that you have oxygen or suction. So I was wondering the same thing. That was one of the things that somebody brought up for us, that do we need this or don't we need this?
Right. So that's exactly why I'm bringing it up. So there are portable kind of suction, the scavenger units that are kind of like wall suction in a suitcase. And yeah, you don't need, well, some people say you should have 100% oxygen, right, to breathe, which could be it's part of the system that you have with your
part
nitrous
of the
tank and
system.
your O2 tank, right? So if everybody has the equipment that has all of that and can use it, then you don't need separate oxygen. But again, there's the crash cart and there's all of the stuff around that. And so most offices just don't have most of this stuff. And I think, again, just to be really clear, it might be helpful. I don't know if we need to. I just really wanted to bring it up because when I talked about this with my manager, that was like a big deal. Oh my God, there's no room for a crash cart. I'm like, we're never gonna, we can't get this up and running because it's just too much equipment, too much stuff. And I was like, well, I'm pretty sure we're gonna need that if we want to use it. So
You also don't need to have it, right? So, I mean, if you don't want to do this and you're not using it a lot, why give nitrous oxide? There are a lot of hazards of it to the environment and other things. So I think it's fine to add it in, the language in. Looks like I might have, I think
So
I
what
ignored the
language-
comment section, but about a crash cart. I thought people just would have a defibrillator in a lot of things. I mean, you go to an airport, they have defibrillators.
Go ahead,
And
Mike.
emergency drugs, you keep in a box, change them
office
every year.
offices don't usually have any of those things hardly.
Mr. Farrell.
Yeah. Hi, everyone. I just wanted to add a little bit of context to this. You adopted an interpretive statement last November to exempt nitrous oxide under certain circumstances. So this comes from that, and the interpretive statement came from 601, which covers the use of anesthesia in office-based procedures. So this language about ACLS comes directly from your rule on office-based surgery. So if you want to change this and make it more specific, you might want to consider also changing 601 as well, because this language is just cut and pasted right over from that rule. It's under subsection 8.
8. Thank you.
8.
Okay. Right, so this is the same or very similar to what we're proposing in the new. This is the established language that Mike is referencing. And we do have 601 open, so you can make changes to it.
Can I ask another question? Maybe Karen, are there, I think of like a crash cart is what we have in the hospital. It has everything in it. Is there a smaller or lesser level of resuscitative equipment that would
You
be
can get,
appropriate?
there are like tackle boxes that are available. And there are portable defibrillators, right? Those are what you see, the portable defibrillators in the airports. They're not crash carts. And they may have
Right.
epinephrine, atropine. These people may not even have an IV, may have IV materials, right? This is the whole thing. A lot of these are folks who don't have an IV in place. I would say, anyway, so, I mean, if you want to add it, it's fine with me. I don't care. I just didn't think, you know, you need an IV ability, start IV, an IV bag. You need, you know, a few drugs for ACLS. And then you call 911. If there's a problem, generally there would not be a problem. The biggest problem I would foresee is myocardial events in old people. And because a lot more than in GYN, this is used a lot in urologics procedures that are painful in old men who have prostate cancer and other things. So anyway, that's just my thought. I have no problem adding it to it. Any more safety thing is fine. Heather's there, so I see Heather.
Yeah, I was just gonna let you know that if you are thinking of adding in sort of the equipment or emergency medications or drugs, the dental commission, because dentists obviously use nitrous quite a bit, they have 2 rules that specifically address equipment and emergency medications, and they do require a defibrillator in their offices as well. Anyway, I can provide those to you if you're interested in looking.
Well, I think since it's vague and since the question's been raised, it seems reasonable to me to have basic resuscitation equipment available in an office.
I think there's going to be a lot of interest in getting this started in a lot of offices. So it might behoove us to have a little bit more specificity in there just to give guidance to people to make sure they really know what they need to invest in before they get their program up and running for office-based procedures.
Heather, real quick, do you know offhand the WAC number that dental has?
You just sent a
Yeah.
Teams message, yeah.
Yeah, I just put a one in the chat, but so 246-817-724 is record keeping equipment, emergency drugs, and then the defibrillator is in a separate rule, but they also have a minimal sedation with nitrous oxide is at 817-740.
I think if the dentists think they should have all this, then the doctors and the PAs should
Well,
have
we
all this.
definitely, yeah, should, yeah.
So should we incorporate some of this language into our proposed rule then?
I think so.
Is that the best way to do it, or do you have a separate like section the way they do?
So we have, let's see. So we're proposing a section about nitrous oxide. That's what we're working on today. I'm not sure. And then obviously we already have the section for office-based surgery.
Yeah, I think we should put this in then.
Okay. I will make some notes and I can work on that. Then Ed, you have your hand raised.
Yes, I just wanted to say that I am grateful that Dr. Curry brought this question up. I think it's important for us to support whatever it takes for patient safety. And I think there's very little downside to adding this in when there is a procedural process going on in the room taking care of patients. So I think, and certainly I would advocate for a simple, and I would like to stress the word simple, way to institute this so that it is adaptable and adoptable.
I think some of these comments have been written into what we proposed, meaning, but not the equipment there. And drugs, those were assumed to be present, I think.
So do you want to talk about more about this proposed language, or do you want to move on to the comments? We can do either one.
Well, there was a comment about pediatrics. I mean, I don't know how many providers will be taking care of a baby and giving nitrous oxide. I mean, really. But I think it's worth seeing the public comments about it. Ms. Boyd, are you going to read these or do we, it's hard to see. It seems very light on my screen. I'm not sure why.
Yeah, I'm not sure why it's so
Yeah.
light, but I can make it
Okay,
bigger.
that's bigger. We can see it.
Okay. You're also able to make it bigger if you hover over the share screen.
Yeah, I could do it. Yeah.
Did you want me to read these?
No, we can. Do
I
people
read
want
them.
anyone without a screen?
Well, they were in the packet, so
Mhm. Yeah.
I think the one about the baby, the pediatric case, is a little further down.
That's this one from Hannah Jones, I think.
Yeah. Oh, I have one other question. In our proposed language, I don't think we specified how often equipment needs to be checked and that sort of thing. Should we, or do we need to do that, have that in there? I mean, most offices will sort of maybe do an annual thing, but do we need to specify that equipment should be regularly inspected?
I'm a little surprised because people using this, you would think they would check it frequently.
Yeah.
Yeah.
I mean, an
My,
ambulatory surgery center would have that in its
yeah,
credentialing, right? Or a hospital, but offices are a little more loosey-goosey.
again, I think that was, again, based on the office space rules. Right, Mike? You have a comment about it?
Yeah, I just wanted to point out that the office-based surgery rule in 601 requires accreditation. So I believe the accrediting entity would take care of that. And actually, that's the driver for this rule you're looking at now. And that is that some entities believed that they ought to be able to use nitrous oxide without the cost and expense and time involved in seeking accreditation. So that's the key difference between these two rules.
Wait, Mike, I'm not sure I understood that. So
Okay.
offices will have to get accredited by who?
By one of your approved accrediting entities, which is CMS or the Joint Commission or Quad ASF or AAAHC. So under your
Wow.
the key
Okay.
part of your office-based surgery rule, Dr. Curry, is that the office has to be accredited. In the nitrous oxide rule, that's absent.
Right. I thought if it was less than 50% nitrous and all of that, then they don't have to go through all the accreditation.
That's correct.
Right.
I'm sorry for the confusion. I'm just pointing out that if they fall within 601, they have to be accredited. And I assume that means the equipment has to be inspected, but under 603, the new rule, there's no accreditation and therefore there's no inspection. And so it may be prudent to put in something about inspecting equipment in this rule, but
Okay.
not in 601.
Right. That's why I was bringing it up. Exactly. Because if we're exempting 603 exempts nitrous oxide at 50% from the more strict accreditation, right? Is what I was
Correct.
understanding.
No, you
Yes.
got it. You got it.
I got it. Okay. So then that's why I was just to, if somebody's using this document to, decide if they're going to invest in everything to do nitrous in the office for procedures, sort of saying, yeah, and don't forget you should, inspect your equipment, keep a log. I mean, really, it just means they're keeping a log, and somebody's signing off that they reviewed everything and checked it all and it's all up to date and working well. But they should do that. I mean, so I'm thinking of like, you can do independent sort of volunteer office-based accreditation, like through the American College of OBGYN. They have a whole program anyway. So there are sort of precedents for just sort of, you keep a log, you have your notebook with all your protocols and your emergency procedures and lists of all the equipment and, how often drugs need to be thrown out and replaced because they've expired and blah, blah, blah. And it's all sort of organized in a way as if you were going to be accredited by JACO or somebody like that, even though you're not going to be. But nevertheless, that's the best practices. That's the standard that you want to maintain within your office. So if I was going to my office manager and trying to set this up, I would say, okay, this is what we need to do. We need to, have all this equipment and have an inspection every year and train all the staff and have the emergency protocols, blah, blah, blah. Kind of like a how-to manual, a little bit. Not quite that detailed, but
That sounds reasonable.
I can work on getting some language added in there for that as well. And I think that conversation covers this comment from Hannah Jones, right?
Well, a part of it is with the baby, but I mean, I didn't see this as being particularly used for babies. It's going to be primarily used for adults. So I don't even know, this whole issue about giving we in anesthesia don't use nitrous oxide very much anymore these days, right? It's a drug. We don't even have it in our operating rooms. So it's a drug that basically is ruining our environment, but it can be helpful to reduce pain when other options like 10 milligrams of diazepam, which only take away your memory but don't take away pain, and it can be useful in adults. I don't know if the dental offices have a restriction on age. I mean, most kids under a year don't have teeth, right? There are very many teeth to have cavities and need to go to the dentist. So I don't know. Diana, you have another comment?
Just that I was going to say the only reason I thought that this might be worth talking about, I have no idea about babies, obviously, either, but I could just see, they've got nitrous, in the OBGYN's practice, and somebody brings their kid in day 3 of life. Oh, I didn't do the circumcision in the hospital. Can you just circ him and give him some nitrous, for the pain relief? I could just see like some scenario where
Yeah,
I don't know. So
but
I thought, well,
the
if it's
requirement is
known,
so much higher for a baby, it's not even going to the requirement goes down as you age. But I mean, a circumcision they do under local, right? I mean, or
well,
nothing,
obviously, but I just
they
do,
won't
again,
remember it. They don't have
do we
good
need,
memory at that age. Yeah.
I know, but do we need to say anything about this in order to prevent that situation from happening if it is not known to be safe for children under 1 year? I, I just don't know. I mean, it's our responsibility to protect the public. And so if we don't say it, does that give people license to do it potentially?
I'm gonna call on Heather to maybe give some input on if we don't add it in there, does that mean that people can do it?
Right, so I don't think if you would need to add a restriction, otherwise there is no restriction. You asked about dentists, they do have a pediatric sedation endorsement that you have to go through, so there's extra training and certain protocols. It does talk about, but it doesn't talk about under 1, it's just talking about pediatrics in general, so there's no delineation about the 1-year-old in their rules. But if you wanted to restrict it to on children less than 1 year of age, you could put that in the rule.
And there wouldn't be like an issue with adding that in there. I mean, it's a restriction, but it sounds like it doesn't happen.
I don't
Well,
think
it
it
doesn't
happens
happen
very
to,
much, but
it doesn't happen
circumcision,
in,
if they're going to use it, yeah.
well, I don't know, or other pediatric procedures, but dentists wouldn't use it because they don't have teeth, as Karen said. So we don't have the dental rules as a guide for this
But it's not a
particular
good anesthetic
situation.
for babies. Okay,
No,
it's just they still move and everything. So
yeah.
I'm fine to make a year. I don't care, personally. I did note, I don't know if it's only the nurse anesthetists who are saying that, who don't, or whether you want to talk to pediatric anesthesiologists who also don't use nitrous oxide. The field has gone away from this drug because it may help in an office, but it's creating global warming among other things, and there are side effects of this drug too. So I'm happy to add it in. I'm not sure if a year or 2 years are any different. Frankly, I don't even think I didn't. The people who approached us about this were largely focused on older patients. And you could see how GYNs might find it important, but pediatricians, I mean, we could not have it given to kids under 10, right? Or something. Or under a certain age.
So I guess that's a question. Do you want it to be less than a year, or do you want it to be less than a different age? Go ahead,
There
Billy.
is somebody here on there.
Hi there, good afternoon. This is Billy Dickinson with the Washington State Medical Association. This is an area I think we can be helpful. We have some pediatric folks in our membership, and we're happy to reach out to the Pediatric Association and get some feedback on this. It sounds like there's going to be another draft of these rules, so maybe at the next workshop, that's something that I can bring back to you or send over via email once I have it. Does that sound like an okay plan?
That sounds
Absolutely.
fine.
Yes.
I would suggest you talk to the people who are specialists in there, which also are not just the ones who may use it, but people at Seattle Children's Hospital. I'd be happy to refer you to anyone because a lot of, in case they're not members of your society or actively involved.
Will do. Thank you very much, Dr. Domino. Thank you, Amelia.
Thank you, Billy. Okay, so we're working on one piece, well, all the pieces of this particular comment. Both of these first comments, I believe, are in support of this rule. So we don't need to do anything with those. And then we received this letter from Billy, who just spoke. And they are also in support. So those are the only comments we received written. And so then it would probably be good to open the floor for any other comments from folks who are here today. It doesn't appear we have any other comments, though.
Okay. Are there any additional questions about the draft language from anybody, since we have no other comments?
And then, oh, go ahead, Hannah.
Hey there, sorry, I hope you can hear me. I'm in a coffee shop, so hopefully there's no background noise. Thank you for the opportunity. I apologize. I think I might have missed the packet, but I wanted to clarify. I'm a contract lobbyist for the nurse anesthetist. And one item they were wondering is whether it's going to be explicitly stated that this applies to nitrous below 50%. Can you just clarify that that's going to be included in this rule?
Yes. It's less than 50%.
Perfect. Thank you. Appreciate it.
50 or less. It's
50 or
something
less.
that's safe.
Thank you, and appreciate the conversation that was had today, considering.
Yeah, and we will
Honest
refer
comments.
people to talk to people at Seattle Children's Hospital for the age cutoff, not knowing that a year is any different than 2 or 3 years, as an example. I mean, I think it's more of what sort of procedures might people want to do in these. And nitrous isn't used a lot anymore in anesthesia, at least in a lot of areas of the country, and especially at Seattle Children's, and also not at University of Washington centers either. We don't have it in our operating rooms.
Apologies, I don't think my raise hand function is working. This is Billy again. I just have a timeline question, if that's appropriate now.
Sure.
So it sounds like there'll be some updates to this draft. Do you have like a ballpark idea of when you'll make those? And when they'll be available for reviewing. I also missed the packet, so just kind of seeing this language.
So, we will start working on the redraft soon, probably next month it will be done. And then when we have the next workshop will kind of depend on, our meeting schedule and the commissioners and things like that. So, I'm pretty sure, Billy, that you are subscribed to our rules
I think so,
delivery
yeah.
distribution list. So we usually send those things out like a couple of weeks in advance if we can. For these workshops, I try to get them out a little bit sooner than that. So I think there should be some, I'm hoping we have another workshop before the end of the year. That would be my preference.
Okay.
So hopefully sometime in October, maybe. It's hard to say. So
that's plenty of time to gather some good feedback. So I appreciate it. Thank you.
Right.
And
So
I apologize for missing the packet.
oh, no worries. So I will get, as soon as I have a redraft done, I will run it through Mr. Farrell because he's the one who wrote the interpretive statement. And he and I have been working together on office-based surgery rules for probably 10 years now. So I will run it through him and collaborate with him on that draft. And then I will post it to our rules in progress site as soon as it's done. And then people can comment. Once it's posted, you can certainly comment to the medical.rules@wmc.wa.gov address. And then we can incorporate some of those comments into the draft before the next workshop. So I will get that up as soon as I can. And then I will send out a notice through that Gov Delivery distribution list for rules that it's available for comments.
That sounds great. Thank you very much.
Sure.
Ms. Boyd, do you have contact information for all those things that you were just mentioning as far as the next steps?
Let me pull that up, please. Okay. So the next steps would be another workshop, at least one. And then after that, it would be to initiate the CR 102. And then you can comment on rules anytime by sending them to this address here, this medical.rules@wmc.wa.gov. And that's any rule, even ones we don't have open right now. You can always send me an email. Typically, if you email me about one that isn't open, I will tell you you would need to fill out a petition for rulemaking, or I can give you an update on rules that we have in progress. And again, if you want to see what we're working on, we do have a website. We pull that up. So if you go to our website and you hover over this policy and rules in the banner, if you just go to rules and regulations in progress. So here's all the rules we have going right now is in this current rules in progress table. So all of these are open and available for comment. And then we try to keep our completed rules up here. If we've completed them within the last like 3 to 5 years. And then anytime we have a workshop, we post it here. And then if there's a hearing, it will also be on this page. So, and if you are subscribed to our Gov Delivery, then, and if you need that subscription address, I can certainly send it. Then you will get notifications anytime we add anything to this page. So, because I typically link to this page in the notification.
Thanks. Ms. Bush has a comment here. I can't read the whole thing. Jimmy, do you want to say something about
No,
this?
it's okay. I'm just posting the links that Amelia is talking about.
Oh, thank you, Jimmy.
Okay, great. Thanks so much. All right. There's the link there in the chat, which you can see now. Is there anyone else who wishes to make any comments or have any further questions?
And then
It-
just real quick, sorry, I would ask if you have any other comments about the draft that we proposed today. If you have any other comments about that, now is the time to provide those comments. Or if you don't feel comfortable speaking, you can always email them to me.
All right. Well, hearing none or seeing no hands raised, is that right? Ms. Boyd, no
Yes.
hands raised? I'd like to thank everyone for their participation and excellent comments and suggestions. And if no one else wants to speak now, I will close the workshop and thank everyone for a great discussion.
Thank you, everyone.
Time is now 4:17 p.m.